I'm Charles Bankhead of MedPage Today, reporting from the American Academy of Pain Medicine meeting in San Antonio. A study of claims records for patients on chronic opioid therapy suggested that almost 80% of patients might be non-adherent, as determined by urine drug testing. Dr. Harry Leiter of Ameritox in Baltimore emphasized that the obvious explanations for non-adherence are not the only explanations.
People automatically jump to the conclusion that patients are abusing or misusing or addicted drugs, but the reality is patients on chronic opiate therapy who have chronic pain, there's many reasons that drive non-adherence. For example, you might have a spike in your pain where it's worse on a given day or a given week, and that may drive you to take more medication than your doctor prescribed, or go to a second doctor, or borrow some medication from a family member or a friend. So that's one type of non-adherence, which could be misuse. So another type of non-adherence could be, we might find out with our urine drug screening, our toxicology screening, our monitoring, that a patient doesn't have any drug in their body. And then that might lead you to believe that the patient's doing something wrong, like selling the drug. But there could be other explanations. They could have side effects from the drug. These drugs all have side effects, and a patient might stop them temporarily because they're having those kinds of side effects, like dizziness or nausea. Similarly, maybe early in a month, they had a spike in pain, took extra medicine, and since usually doctors prescribe a month's supply at a time, they might have run out at the end of the month, and therefore when you test them, they have no drug in their body.
Non-adherence added about 15% to the cost of care as compared with patients whose urine drug testing indicated they were adherent.
So our economic study really was looking at how the costs of medical care compared between patients that looked like they were adherent according to the drug monitoring compared to a group that looked like they weren't. And to see whether those patients, the hypothesis was the patients that are non-adherent cost more money to take care of.
Drug testing can provide physicians with useful clinical and financial information.
The financial information is important for many doctors and clinicians who say, you know what, I'm nervous about doing drug monitoring because it costs money and I don't want to add cost to the healthcare system. Or I'm worried that payers will be annoyed or concerned if I order drug monitoring tests on all my patients. This data is now being viewed by many payers very favorably in the sense that the average cost of patients on chronic opioid therapy is over $20,000 a year. So the cost of this testing to try to determine who's adherent and who isn't, and to help doctors get more patients to be adherent, is a very small fraction of that $20,000 cost. The second thing is it's powerful information that doctors can use and health plans can use to support this testing, because there are obviously clinical benefits, preventing people from being hospitalized, right, that we found in our study if you can keep the patients adherent. This testing isn't just about playing cop and finding people doing something wrong. It really is a way that can improve quality of care and save the health system money.
The optimal interval for testing hasn't been determined, Leiter said. However, many pain experts believe that 3 to 4 times a year will be sufficient for most patients. High-risk patients may require more frequent testing. From the American Academy of Pain Medicine meeting in San Antonio, I'm Charles Bankhead, MedPage Today.